Well, good evening, ladies and gentlemen, and welcome to this Wolper Wellbeing Forum on living with Parkinson's disease, how to stay independent and keep living well. And our webinar this evening is hosted by Wolper Jewish Hospital and Friends of Wolper, and our partner tonight is Parkinson's New South Wales. And I'd like to give an especially warm welcome to those of you who are joining us for the first time. My name's Julie McCrossin, and it's my pleasure to be your MC this evening. Let me begin by acknowledging that we're broadcasting to you on the land of the Gadigal people from the Sydney area, and we pay our respects to elders past, present and emerging. Some quick housekeeping as more people join us. Your questions are welcome tonight. You'll see down the bottom of the screen a Q&A button. If you can click on that and put your questions in there throughout the webinar, they're welcome. And thank you to everyone who sent questions in advance for this evening's webinar. Now, we cannot see or hear you as an audience, so your only way of communicating with us is via the Q&A button. And our question moderator tonight is Dr. Alan Schell, and I'll be bringing him on regularly. He's watching all the questions. He's got the earlier questions, and he'll bring the audience questions to our panel. We're going to answer as many as possible, but of course we can't give individual medical or health advice. And a reminder that this webinar is being recorded, and so the video of it will be available on the Wolper Jewish Hospital website after a few days. So let's welcome now Dr. Alan Schell, an experienced retired general practitioner with a long association with Wolper and the Wellbeing program. This is deaf sign clapping, so welcome to you, Alan.
Thank you, Julie, and thank you for organising this evening. And just a message from the board of the hospital that today we remember and honour bravery and sacrifice of soldiers, police officers and all innocent victims of senseless terror. Our hearts ache for the families who've experienced unimaginable loss, and we pray for the safe return of the hostages, the end of all loss of innocent life, and hope for an everlasting peace. Thank you, Julie.
Thank you very much, Alan, and amen to that. Well, if you are joining us for the first time and you're not familiar with Wolper Jewish Hospital, I should tell you that it's a not-for-profit hospital providing rehabilitation, medical and palliative care to people from all cultural and religious backgrounds within a framework of Jewish culture, religious and dietary requirements. And it's in the eastern suburbs of Sydney. Well, as I said at the beginning, it's my pleasure to welcome a representative tonight from our partner, Parkinson's New South Wales. So please make Mary Kay Walker welcome to introduce our theme. Welcome to you.
Thank you so much, Julie, and good evening, everyone. Look, I realise that this is a packed agenda, so I won't take up too much time. I did, though, want to acknowledge the wonderful partnership that Wolper and Parkinson's New South Wales has enjoyed for many, many years, and we're thrilled to be partnering with the hospital this evening. It's an appropriate and timely that Wolper is hosting this wellbeing event in May, when the memories of April, which is Parkinson's Awareness Month, are still fresh in our minds. We're very grateful for the focus that a hospital of Wolper's calibre is bringing to the needs of our Parkinson's community. To quote the distinguished neurologists and researchers Ray Dorsey, Bastian Bloom, and their collaborators in a paper published in 2018, there is now a need for heightened activism, focused planning, and novel approaches in the treatment and care for all those living with Parkinson's. These novel approaches, of course, include dedicated research and treatment innovations in labs, clinics and hospitals like Wolper across the world. We must also continue to innovate and expand services for those living with Parkinson's, whose numbers are already high and growing. That's where organisations like Parkinson's New South Wales come in. We are the only not-for-profit organisation in New South Wales solely devoted to delivering services which enable people to live their best lives with Parkinson's while also meeting the challenges and needs of their care partners. Our mission is to provide evidence-based support, particularly psychosocial support, and pathways to care to keep people at home in their familiar family situations and communities for as long as safely possible. The point of entry to our services is a 1-800 free call info line service, staffed by registered nurses and allied health professionals. The info line is a one-stop shop for evidence-based information and advice on all things Parkinson's. And it's a single point of connection with our other services, including our network of more than 70 in-person and online support groups. This network covers most of New South Wales, and 70% of the groups are in rural and regional areas of the state. We have 4 community-based Parkinson's specialist nurses currently in the Tweed Heads, Port Macquarie, Coffs Harbour and Goulburn. We work closely with other LHDs and advocate widely for more Parkinson's specialist nurses in the community, as we know that these nurses ensure that those with Parkinson's are kept out of emergency departments and hospitals, and if they do present, then their stay is shortened. We have access to specialist counselling around the psychosocial impacts of Parkinson's for those living with the disease and their care partners. We have in-person and online education programs for GPs, allied health and consumers, and we have an extensive Parkinson's information resource centre. All of this is delivered at no cost to the people needing our support and service. Despite Parkinson's in Australia being more prevalent than many of the most common cancers combined, it is woefully funded when compared with these other diseases. In terms of state government support, our organisation receives just 47 cents per person living with Parkinson's in New South Wales. For everything else, and that's around 97% of our income, we are dependent on the generosity of our donors. Like the people living with Parkinson's and families we support, our challenges are many, but we don't have the option of turning away or scaling back our efforts. Occasions like this Wellbeing event and April Parkinson's Awareness Month are reminders that we are in this fight for the long term. We are with the Parkinson's community and the Wolper community every step of the way. And I'll hand back over to you now, Julie.
Thank you so much. That was so informative and so helpful, and we'll put a link to your website when we send out an email after our session today. So thank you very much to Mary Kay Walker. And welcome if you've just joined us. Our webinar is all about living with Parkinson's disease and living the best possible life. And just before I invite all our panel and we begin to answer your questions, we've just got a few poll questions for you to answer so our panel members can learn a little bit about you. So I'm going to read the questions. I then shut up while you answer the questions on screen, and then I give you the answers immediately. So Nat is our technical operator, and I'll ask you, Nat, to commence with our first question. Gender, your gender, male, female, other, prefer not to say. Please answer. And let's see what we have. Thanks, Nat. So 49% male, 51% female. Thank you very much. Our next question, please. Your age range, 39 or younger, 40 to 60, 61 to 70, 71 or older. So 3% 39 or under, 14% 40 to 60, 27% 61 to 70, and 56% 71 or older. Thank you for joining us. Our next question. Do you have a diagnosis of Parkinson's disease? Does a family member or friend have a diagnosis of Parkinson's disease? Please answer each of these questions. So yes, a diagnosis for 46% of our audience tonight. Welcome, welcome, welcome. No to 54%. And a family member or friend, yes to 56% of our audience. So thank you very, very much for being here. We'll go to our next question. Now we've got 3 questions. I'll read them and then you'll answer all 3. Do you or your family member experience poorly controlled physical symptoms, slowness, tremor, balance, despite treatment? The second, do you or the person you know experience non-physical, non-motor symptoms, including poor cognition, mood disturbance, hallucinations, delusions, impulse control disorder, so pathological gambling, fainting, constipation, bladder dysfunction, fragmented sleep, dream enactment? And thirdly, do you or the person you know actively engage in rehabilitation or allied healthcare, for example, physiotherapy, speech therapy, counselling? If you could answer, please. So poorly controlled physical symptoms despite treatment, 71% of our audience has said yes. Are you or the person you know experiencing non-physical symptoms? 73% have said yes to that wide variety of symptoms mentioned there. And if you are able to get to the lower end, I don't know if you can scroll down, Nat. We can't see the third question.
I don't know if I can scroll. I think you have to scroll it, Julie, because each person is independent.
Thank you very much. Thanks, Nat. And number 3, do you or the person you know actively engage in rehabilitation or allied healthcare? 68% yes, 32% no. Thank you very much. Our next question, please. Do you or the person you know does the medication, sorry, let me start again. Does your medication or the medication of the person you know control the Parkinson's disease symptoms well throughout the day? Yes or no? I think we'll see the answer. Yes, 60%, no, 40%. And I think we have just 2 more questions. Regarding speech, do you or the person you know experience problems with the volume of voice or clarity of speech? Yes or no? Thanks, Nat. Yes to 64%, no 36%. And one more, I think, to do with exercise, please. Physical activity. In the past week, on how many days did you or the person you know do a total of 30 minutes or more physical activity, which was enough to raise the breathing rate? And this could include sport, exercise, housework, but not physical activity that may be part of the job. And you can see you've got a lot of choices there. I'll let you click the one you prefer. And the answer, please, Nat. So 15% none, 1 day, 6%, 2 days, 20%, 3 days, 14%, 4 days, 16%, 5 days, 10%. Well, look, thank you to all of you for answering those questions, which are, of course, completely anonymous. And it gives me great pleasure now to welcome the panel who are going to discuss living with Parkinson's disease, how to stay independent and living well. So if I could invite onto the screen Professor Simon Lewis, a neurologist, Associate Professor Stephen Tisch, a neurologist, Kristin, a speech-language pathologist, and also Associate Professor Natalie Allen. And I'm just greeting you all, and we'll be featuring each person. I'll tell you a little bit more about each person as I bring them on. If I could come to you, Professor Simon Lewis, first, if I may. You're a neurologist, a professor of cognitive neurology at Macquarie University, a distinguished and experienced researcher with a particular interest in quality of life for people with neurodegenerative disorders. We have a very large number of people actually with a diagnosis watching us this evening, and I just do want to reassure that throughout the evening we will be bringing hope-rich information about living the best possible life for as long as possible. And I just wanted to make that clear. But Simon, could we begin with a definition of Parkinson's? You know, what is it and what are the early signs to watch out for? Welcome.
Well, thanks very much for having us on. I think the simple question you've asked is actually raging at the moment in the research community. People are actually wondering whether we need to change the diagnosis, the diagnostic criteria, whether we're at a stage now where we might be able to do things like blood tests or spinal fluid to make a diagnosis. But essentially what we're talking about is a clinical condition that at the moment is diagnosed on its clinical symptoms and its examination findings and some of the investigations. So in the brain, what is happening is that cells are dying in a pattern that gives a specific basic constellation of symptoms, which present then in different ways. And I think the delay to diagnosis we see is often because there are physical and non-physical symptoms. So someone presenting to their GP with a tremor, relatively easy to think, yes, that should see a neurologist. Somebody presenting with constipation who then also has some slowness or stiffness makes it very challenging for the non-specialist. So we see these delays in diagnosis, but we're looking at a condition which essentially is mapped out by slowness, stiffness, and or tremor that essentially fits a clinical diagnostic criteria.
Now, are there enough neurologists? If you could explain what a neurologist is, and then are there enough?
I think so a neurologist is someone who specializes in diseases of the nervous system, the central nervous system, peripheral nervous system, as well as muscles. And the truth is that I think Australia has probably not enough neurologists. And of the neurologists that we have, the trouble with a specialty like neurology is it's very, very broad. So you might have stroke disease, multiple sclerosis, epilepsy. So then you sort of say, well, how many people are specialists in Parkinson's disease? And that number gets increasingly small. So it's often very challenging. And there are a number of other specialties that can do this. So geriatricians see a lot of Parkinson's disease. So it's not only neurologists who are looking after these patients, but certainly the number of people who are expert in Parkinson's disease is too small for the number of patients we have.
So if this was an audience of general practitioners, and one of them said, when should I refer my patient for an assessment by a neurologist or a geriatrician, what would you say?
The moment you think about the diagnosis. Because the bottom line is that it's a really hard diagnosis to make. People like myself struggle with it all the time. And the fact of the matter is that most GPs will have maybe 3 or 4 patients. One of those patients might be under 40, one of them might be over 90. They look completely different. So I think it's asking too much of GPs to get beyond the question, should I refer this on? Yes, please, send it as soon as you can.
Because would I be right in thinking that early diagnosis is helpful for the patient?
I think it helps to set the agenda. So unlike cancer, where you say, well, we need to make a diagnosis early because we have treatments that we think will change the course of history, as it were. Here we're in a situation where at the moment, we don't have a treatment that will stop this disease in its tracks, but people are working on those trials and hopefully we'll get closer to that. But in terms of being able to set a patient up and saying, okay, well, I think for you need to be thinking about where you're going to live, what supports you're going to need, how long you want to be working, what lifestyle changes you want to make, and actually thinking about, where your life is going. Having that conversation very early, I think, is important.
And I think you believe that it's important to try to find a neurologist or a relevant doctor who will explain all the possible options of treatment, which I guess involves both expertise and time. What are the options that you think it's important for someone with a diagnosis to know about in terms of treatment options?
Yeah, so I think when I have this conversation with the newly diagnosed patient, I generally start by saying, look, we have treatments that are medication based and we have treatments that are non-medication based. The non-medication based treatments are obligatory. So every patient with Parkinson's disease should be taking very seriously rehabilitation strategies, exercise, speech therapy, physiotherapy, and also things like cognitive training online to try and, maximize their future. Because when we see someone, let's say they're 65, they may be living until their late 80s. And it's about putting the investment in when you're young enough to get the benefits as you age. In terms of the medications, we have a number of symptomatic treatments that are very good at controlling the symptoms. And these tend to work for a few years in most patients at a level that will keep them very, very independent. However, when those, if you like, medications start to fail and patients notice their symptoms coming in and they can't get optimized, then that's when we need to think about some of the smart therapies that I think people like Steve Tisch are absolutely, leading the field in.
Thank you. And I'll come to Steve. Well, I might come to Steve Tisch now, and I'll return to you because I know people are very keen to hear about your research and so on. But welcome, if I may now, Associate Professor Stephen Tisch, another neurologist, head of the Department of Neurology at St Vincent's Hospital in Sydney, a researcher, and also someone teaching at the University of New South Wales, and I think the Australian Catholic University as well. Just reference to smart therapies, was that the term? What does that mean? What do we need to know about here?
Yeah, so as Simon made the point very clearly, most patients derive substantial benefit from medication for a number of years, and that number of years can be sometimes very long. In younger onset disease, we often can maintain patients at a good level of functional independence in the community for the first 10 years of the disease, which is a very long time. Even in those patients, it's very common for the good response to medication to become unstable. So what happens is that they don't lose their response completely, but rather it becomes uneven, and they might have periods of the day where they're good, and they have to sort of, budget their time to do their important things while the medicines are working. And conversely, there'll be periods where the medicines are not working well, where their motor function will decline, and we'll see a return of those classic symptoms that Simon alluded to as part of the diagnostic criteria, such as slowness, stiffness, trembling, gait difficulty. So we move from a phase of sort of steady benefit from medication in the early years of the disease to subsequently still benefit, but in a brittle and uneven manner, which starts to create its own problems. When patients start to move into that uneven benefit phase, and not every patient will have the right profile to develop those so-called motor fluctuations, but for those that do, there are some instrumental and technology-assisted therapies which are rather effective in smoothing out the unevenness and providing a reasonable, steady benefit throughout the day, which can actually have quite a helpful effect in improving people's quality of life.
And just before I go to each of them in a little bit of detail, could you just list the 2 or 3 key therapies or interventions we're going to discuss tonight?
Well, we broadly group them as device-assisted or technology-based therapies. Some of them are derivatives of medication, but delivered in a more sophisticated manner. So normally when patients take medication, it's tablets, as you might expect. They're taken orally at intervals during the day, and the regimes often get more and more complex as the disease progresses. So patients might start with 1 tablet 3 times a day in the early years of the disease, and then it becomes 4 times a day. And as the disease rolls on, they're needing more frequent dosing to keep up with their symptoms because their response is becoming more uneven. One of the reasons it's getting uneven is not due to Parkinson's itself, but more due to a byproduct of oral medications. They don't really stay in the body for very long. They go up and they go down. So when you think about that, you still have a powerful treatment, but it's really the delivery that's letting us down. So some of the more effective technology-based or device-assisted treatments deliver the medicine via a continuous infusion. And what that does is it gets around that issue of intermittent levels due to oral ingestion and puts the patient on a sort of a steady flow which can have quite a transformative effect on symptom control. And the two currently available commercial systems for continuous dopaminergic infusion include subcutaneous apomorphine, which is a high-potency dopamine agonist administered by a small pump, probably about the size of 2 iPhones. It's quite small, with a small fine plastic catheter and a needle under the skin, not dissimilar to a diabetic pump. Okay, and with that system worn during the day, patients can get a steady benefit from their medicine, which can various sort of well-designed studies and more than 25 years of clinical experience have shown us that that has a stabilizing effect on these unstable motor responses and can improve on time, which is the portion of the day where people are in a good motor state, where they can undertake their activities of daily living and perform at a better level. But usually that improvement in on time also translates to an improvement in quality of life. There are also
could I just quickly say, people watching this are going to think, well, when should I try to find your kind of neurologist? Or does one rely on one's treating neurologist to transfer you to these options?
A lot of patients don't need these options, to be honest. They certainly don't need them at the beginning, because what we normally see, as Simon put really eloquently, is we have highly effective, relatively simple office-based treatments which work, incredibly well, really. And many of those patients will derive enormous benefit that enables them to lead active and full lives for many, many years of the disease. And it's really only a subgroup of patients who end up plagued by these unstable motor responses where device-assisted therapies become worthwhile or even necessary. So I would see it more as a niche therapy. It's not for everyone, and it's certainly not at the beginning of the disease. People don't fluctuate at the beginning of the disease. At the beginning of the disease, people have a stable response to their medication that we call the long duration response, which is like filling up a bath. You take your tablets. If you stay on them for a number of weeks or months, you reach a steady state, and most patients have continuous benefit from medication that varies very little throughout the day. It might change a little bit depending on fatigue or whether they've exercised or whether they've been sitting for a long time, but the basic benefit is maintained. These unstable responses that are enough to make people suffer in terms of activities of daily living are really a phenomenon that we rarely see before 5 years of disease, and for most patients don't become a real issue until 10 years of disease. So as you can see, we're already dealing with a subgroup of patients, not everyone.
Thank you very much. If you could stay with me, but could I invite Professor Simon Lewis back onto the screen as well? And I know we're going to hear about more smart therapies, but if I could welcome Simon back. I realised I didn't ask you about side effects of medication. Is there anything we should let our audience know about that when they're in that initial period where the medication's working, but are there side effects we need to be aware of?
Yeah, look, I think it's impossible to find a tablet that doesn't have a potential side effect. But I think when you are in a conversation with someone with Parkinson's disease, you've got to weigh up what risks and benefits mean. And so essentially, we're talking about a disease that before we had any treatment would mean that your average life expectancy was about 6 years. So when we're talking about giving patients tablets, what we're really saying is, look, without tablets, this disease used to kill people. Now it's fair to say that it's a life sentence. It doesn't kill you, you live with it. So when we talk about the side effects, I think it's fair to say that they have to be balanced against the disease itself. Now, those problems with the disease not being treated are sort of immobility, falls, all those issues. So in terms of the side effects, I mean, the mainstay of treatment is levodopa, which essentially is replacing a chemical that your brain normally makes, but you don't have enough cells to make enough of it. So that does have an artificial way of being delivered. It can do things like lowering your blood pressure, making you a bit more sleepy. But in the early stages of the disease, most people aren't going to notice any of those side effects. A class of drug where essentially you block the enzyme that's breaking down dopamine in the brain, what we call the monoamine oxidase inhibitors, which sulfonamide, razagiline would be the two drugs that we have currently. Their side effect profile is very, very low indeed, almost equal to a placebo. And then the class that gets most of the press are the dopamine agonists. These are a drug that basically pretend to be dopamine and like a skeleton key, can work on the dopamine receptors. You generally can get away with taking it once a day. The commonest side effect would be sleepiness. So we tell people to take it at night, help your night's sleep. And the rare side effect, which you can almost predict who's likely to get it, is what we call impulse control disorders, where you might trigger pathological gambling, overspending, hypersexuality. But those risks are very, very small. And if you see that behavior, then you can just stop the drug. So I think on balance, we worry far too much about side effects of the drug and not enough about what the disease is doing to you.
Gentlemen, we have many more questions, but I'd like to, if I may, invite Alan Schell, our general practitioner, on for some audience questions, and then we'll be coming back and we'll also be hearing from our speech pathologist and physiotherapist. But welcome to Alan Schell, our question moderator.
Thanks, Julie, and thanks to everybody who sent in some questions already. I think one that's interesting is the issue, and you haven't mentioned it, is the accumulation of cyanonuclein, which is part of the Parkinson's disease pathology, and the issues of whether is there immunotherapy that might be helpful in the new medications, and or is there something we can do to stop that accumulation?
Look, thank you. I didn't see Alan on my screen, but others may have done so. Could I ask Professor Simon Lewis to respond to that question, please?
Yeah, for sure. So there are a number of disease-modifying therapies that are in play at the moment. So just to take Alan's point, essentially, when we look at the brain of someone with Parkinson's disease after they passed away, what we see is that there are cells missing, which used to make the chemical dopamine, as well as a number of other cells. But in the cells that are dying, that are still there, we see these accumulation of a protein called alpha-synuclein. Now, alpha-synuclein is a protein that should be inside cells. It's usually very important. But essentially, in this scenario, that alpha-synuclein has clumped together. It's become tangled. And that's what you see in the microscope as a Lewy body. So when somebody says, oh, do I have Lewy bodies in my brain? Well, yes, is the answer with Parkinson's disease and dementia with Lewy bodies, which is also a synuclein disease. So effectively, what we don't know at the moment is whether that alpha-synuclein is the baddie and is killing the cells, or it was trying to save the cells and it was maybe trying to mop up things at the time. The approach by Big Pharma has been to try and target that alpha-synuclein with a treatment called monoclonal antibodies. So people will be aware that when you get an infection, your body fights the infection by creating antibodies. So the principle is, if you could manufacture an antibody that would fight synuclein, stop it clumping together, stop it moving cell to cell, then that might be beneficial. The trials that have been done and published in that approach have been unsuccessful to date. And I think people are looking at it a bit like they do with Alzheimer's disease, which also followed the monoclonal antibody route, targeting a different protein. The truth is that it's going to be hard to target alpha-synuclein because it's inside cells, and monoclonal antibodies would have to get inside the cell. But people are going to keep trying. In Alzheimer's land, it took about 25 years before they got a therapy that might help a bit. And I think most of us are a little bit dubious about that. There are a whole host of other approaches to try and slow down the disease. The Australian Parkinson's Mission, which I'm the clinical lead for, and Steve is wonderful, is wonderful leading one of the sites on those trials, is actually trialing a different approach using repurposed medications, so drugs that we already have that we think might slow the progression of Parkinson's disease by targeting some of the pathways that we know are abnormal in the brain. So those are ongoing studies, and I saw that someone had put the question in the chat box. Many people on the call will realize that I've got a website with over 100 videos of me banging on about these questions because they're really important and people need access. So I'll put a link to a video that I recorded a few years ago about what drugs and what trials are ongoing, and that might be beneficial for everyone to go and visit.
Thank you, Simon. I've been on your website and indeed saw, at first I thought you posted a lot of pictures of yourself, and then I realized that they were videos I could click and get information. But could I just ask you, before I let you go and we come back to Alan, people obviously, well, so many people with a diagnosis watching, people are keen to know, you've given some indication there in what you've just said, where is the hope in the current research? And if you could also explain the importance of joining clinical trials. Staying with Simon Lewis, please.
Yeah, so I think it's fair to say that 10 years ago, if I'd been asked that question, I'd have said, oh, look, we're really not in that space. But in the last 5 to 10 years, we've really had an explosion of people targeting Parkinson's disease, trying to slow down the cell death. Cure is a 4-letter word, but I think it's important for us to be aiming towards it. Now, the victories we've had have been very modest. There is, work going on in the UK looking at a diabetes drug that's is in a phase 3 study, which is the study you would use to try and prove definitively whether a treatment is helpful. And there are a number of other studies that are hoping to get into that level. But at the moment, we don't have a treatment that will slow the progression of cell death. But there are lots of people actually working on this. And compared to where we were 10 years ago, this field is exploding. And we don't have guinea pigs with fur that go on. I mean, just so everyone's clear, humans are the only creature on the planet that get Parkinson's disease. So you can't do a trial with a guinea pig. You have to have patients. And unfortunately, not every patient is suitable for every trial. And the bottom line is you won't know, and the researchers may not know until we get you in and have a look at everything and say, yeah, actually, you're a good candidate. And it can feel very, hard because you go, well, am I getting the sugar pill or am I getting the real deal? And you go, well, we don't even know if the real deal works. But if you're not going to be in the trials, how are we ever going to know? So I think it's really important that people step up and say, yeah, I want to be part of the solution if I can.
And referring back to Mary Kay Walker's opening presentation from Parkinson's New South Wales, I had the sense there was insufficient funds in this area. Is that true too in relation to research? Should we be lobbying our local members or advocating for funding?
Yeah, I think the bottom line is that it all needs funding. The fact of the matter is that people don't realize how expensive trials are. So if you were talking about some of the trials that I'm involved in, which would have 200 patients using drugs that we already have, doing some of the testing that we do, you're talking about $6 to $10 million. By the time you talk about those monoclonal antibody trials, you're talking of tens of millions of dollars. So lobbying a local member probably is better used to get you a Parkinson's nurse, better access to a specialist, better, services so that you can get, all of the things that we know already work and a coordinated system, because, that's what keeps people out of nursing homes.
Look, thank you. I'll come back to Alan and I'll soon be coming to our allied health professionals. But Alan, another audience question, please.
Yes, carrying on from Professor Tisch's information with regard to technological-based treatments, a number of people talked about ultrasound and operations we can do to stimulate or reduce the impact of tremors. Is that something that's hopeful or useful in the future?
Thank you, Stephen.
Thanks, Alan. Great question. It's certainly something we've tried to implement, and we've treated about 20 Parkinson's patients since 2018 with MRI-guided focused ultrasound. Just by way of background, that's a sort of, putting it bluntly, a high-energy brain zapper that uses a sophisticated apparatus to deliver focused beams of ultrasound through the scalp and through the skull incisionlessly to deliver a treatment dose at specific brain targets that we can control with great precision with sub-millimetric accuracy within the brain. And effectively, we're making small ablations or lesions. So it's really a revisitation of an earlier technique, but using very modern technology. The appeal being that it's incisionless and it has some safety advantages over open surgery because we're not passing instruments into the brain. So if there's some sort of gain of function or overactivity within circuits that's causing mischief, like tremor, spasms or jerking, we have a higher chance of success because we can make a small lesion to kind of interrupt the activity and calm that activity down. We're not as good at putting something back that's missing, for example. So if someone had a cognitive problem where there's obviously something missing in terms of their cognition, we're not going to be able to put that back by making a lesion. So that's just to sort of put it in some context. Having said that, in our experience to date with focused ultrasound for Parkinson's tremor, we've had decidedly mixed results. We're just in the process of finalising a paper that we're hoping to submit in the next couple of weeks, which has looked at our first 18 patients with PD tremor. And without sort of preempting the results of that paper too much, it's fair to say that it was a split field. About half the patients achieved very satisfactory benefit, after a year or more, so a sustained benefit for tremor reduction. The other half didn't benefit. They may have benefited transiently, but not in the long term. So it seems as though at the moment it's slightly hit and miss for Parkinson's tremor, and we don't really have a clear biological tool or clinical sort of methods to differentiate who will be a good responder and who won't. So we haven't actually sort of shut our doors to offering focused ultrasound for PD tremor at this point, because obviously we've seen some good results and some very satisfied patients. But if we are to consider it, we set very balanced expectations, pointing out this sort of slightly hit and miss success rate. I should add that the hit and miss is not related to the lesion size or lesion placement. So the lesion can be perfectly placed and perfectly the correct size, even in the non-responders. It's something to do with their circuitry. And Simon's already touched on heterogeneity in Parkinson's. By that I mean you can have two Parkinson's patients sitting next to you, both fulfill the criteria for the diagnosis, but they're completely different. So I suspect that that heterogeneity also translates into different circuit models, and that although both patients might have PD tremor, the underlying circuit that's misfiring might be different in both patients. So that's why sometimes we get success and sometimes we don't. There's still a lot more work to be done in that space. So I think where it stands, at least in our hands in Parkinson's, is that it's a sometimes effective treatment for tremor, but not the wider range of motor symptoms, nor any of the more debilitating non-motor symptoms as the disease progresses. But it's a promising tool and one we're continuing to work with.
Stephen, just before I come back to Alan for another question, while I have you, we haven't yet spoken about deep brain stimulation. Is that correct? Could you explain?
I don't think we've mentioned that. I think it was.
Could you explain it and when that's useful?
So when we were talking about patients with unstable motor responses, with periods of the day where they're doing well and other periods where they're really struggling because their medication response is unstable, we call that motor fluctuation, on-off fluctuation. Often those patients also have involuntary movements at various points in the day. We call those dyskinesias. With no disrespect to the great Michael J. Fox, if any of you have watched him on TV, he often is exhibiting dyskinesia as an example of someone with dyskinesia, as he's sort of lived with Parkinson's for many years. So those regularly involuntary movements, as well as off periods where people are slow, stiff and trembly with gait difficulty, they are kind of like the bad phase of Parkinson's. With deep brain stimulation, it's not a magic trick, but what we can do is using effectively electrical medicine, we can lift patients to a level similar to their best response to their medication, but on a more continuous basis. So they still need to retain a good phase. If someone is permanently in a bad phase and their medications are no longer conferring any appreciable benefit, they're unlikely to benefit from DBS either. If, however, they're having phases of the day where they're quite good and they can function, more independently with better function, and then other points in the day where they're deteriorating with cardinal symptoms such as slowness, stiffness, tremor, or dyskinesia, then we have the opportunity to consider deep brain stimulation, which is effectively brain pacing. It's rather similar to a cardiac pacemaker, except rather than putting the electrodes in the heart, we're putting the electrodes in the brain. But the small electrical pacemaker that we use to deliver the electrical impulses is very similar. It's even made by the same company. And we can program and fine-tune those impulses to try and optimize the regulation of the motor response. So it sits in that category of therapies that we alluded to before, the so-called technology-based or device-assisted therapies, right alongside the apomorphine that I mentioned, and right alongside the one that we didn't mention, which is the intestinal levodopa gel, which some listeners may be familiar with. And that's a sort of continuous infusion of a sort of toothpaste-like gel that contains levodopa, the magic drug. So levodopa is the principal constituent in Kinsin, Cinemet, Matapar, Stalevo. It can be delivered as a gel directly into the small bowel via a body-worn infusion pump that's about the size of a Walkman. And when one delivers it in that manner, we overcome many of the irregularities associated with oral dosing. So a moment ago, Simon and I were talking about unevenness in medication levels due to oral administration. When you give levodopa as a continuous intestinal infusion, it's possible to achieve a steady state where patients can be maintained in the on state for a larger proportion of their waking day. So that's also a very powerful treatment.
Just very quickly, because I'm lunging to allied health. I just want to ask, with the deep brain stimulation, we've got our little pack somewhere. Is a little wire going up inside?
Correct. That's a good point, Julie. So basically I can show on myself, typically in the right upper chest, there's a small implanted pulse generator about the size of a matchbox. It's all hidden under the skin. It's fully implanted. Then there'd be a little cable running up behind your ear that's about the thickness of less than a pencil, very thin. And then moving up, you'd feel a little lump behind your head and then two little lumps where the electrodes are actually implanted. You need one on both sides of the brain because most Parkinson's patients have bilateral symptoms. Therefore, they need bilateral brain stimulation. Your listeners might be aware that the left side of the brain controls the right side of the body. It's sort of back to front. So in order to get good whole body control, we actually need two electrodes.
Look, thank you so much. I'm going to give you some deaf sign clapping to both our...
I did a bit by mistake then.
But what I'd like to do now, if I may, is to invite onto the screen our two members of the allied health community, Kristin Arthur and also Associate Professor Natalie Allen. Nat, if you could bring them both on together, I'd be most grateful. And it's welcome, first of all, to Kristin. And Kristin is a speech language pathologist, mainly has been in private practice, but also has a master's from Macquarie University, and she has a special interest in neurodegenerative diseases, especially Parkinson's, and is involved at Wolper, I think, on 1 day a week. And welcome also to Associate Professor Natalie Allen, who's a physiotherapist at the University of Sydney, an academic, and her research focus is particularly on exercise for people with Parkinson's. And it's all about, I think your key message is exercise is critical for living well, reducing falls and managing pain. So welcome. The reason I brought you both on is, if I may, before we go to your professional technical skills, just a thought from each of you on supporting the person with a diagnosis and their family emotionally, because we've been listening for about 45 minutes and I've had a sort of cancer that's known as a tough gig, and Parkinson's it's a tough gig. So in your experience, if I may come to you, Kristin, first, our speech pathologist, what helps the patient, the person with the diagnosis, to handle this experience?
So many things, I think. Support of every nature.
You run a group at Wolper, don't you?
Oh, yeah, that's where we're going. Yes, of course. Yeah, I want to call out to our my fellow speech pathologist, Betsy, and we co-facilitate a young onset Parkinson's support group once a month at Wolper. And I think that's, the old saying, a problem shared is a problem halved. I think our members who come to our meetings, we often have guest speakers once a month. I think they get some valuable information, they share a lot of information, but the most valuable thing I think they benefit that they gain from coming to the support group is just knowing that they're not alone, knowing that they're not the only ones, and that there are other people going through who have similar problems, and they can share.
And I'm mindful that Parkinson's New South Wales, our speaker earlier, Mary Kay Walker, talked about groups and support and some of these Parkinson's specialist nurses in certain parts of New South Wales. I guess as someone who's had a serious diagnosis, to keep fronting for the treatments takes fortitude and commitment, and to manage it emotionally can be quite significant. Your thoughts, Natalie Allen? I know you've practiced as a physiotherapist as well as your academic career.
Yeah, that's right. Look, it really is such a life-changing moment for someone to find out that they have a degenerative condition like Parkinson's disease. And often people have sort of that stereotype of Parkinson's disease in their head of what that looks like, you know, a person that perhaps is very stooped and has a tremor and shuffles and things like that. And I think yeah, just really helping the person to understand that people can live well with Parkinson's disease. You know, we've just heard the doctors tell us about the medications and the different therapies that are available and things like that. So I think trying to help people understand that you can live well with the condition, and while help for people with Parkinson's disease on a multidisciplinary level is perhaps not as well coordinated in Australia as what we would like, there are people out there that do have the expertise to help people and provide information. And Parkinson's New South Wales is a really great organisation for really helping to connect people to the services that they need at the time that they need them, and all of that kind of thing. And the work they've done with the Parkinson's nurses helping to coordinate people's care. So yeah, it helping people on their sort of journey to acceptance, I suppose, where they start to understand what it actually means and what it actually looks like, and information and support is a big part of that.
If I could just come to your expertise and research around exercise. I mean, you basically think exercise is as important as the medications and other things we've been hearing about. So put your case. Why is exercise critical for the people viewing tonight with a diagnosis?
I think exercise is critical for the people viewing tonight, whether they have Parkinson's disease or not, actually. We know these days that, you know, exercise, you know, for human beings in general is incredibly important for health and well-being in all sorts of ways. But for people with Parkinson's disease, it's particularly important. So we've been hearing about some of the impairments and the movement problems that people with Parkinson's have, where they move slowly. They might have problems with stiffness, problems with balance. So they might start to have difficulties where they start to fall and things like that. They also might experience problems like pain, which sometimes comes along with the disease process, and the stiffness and those sorts of symptoms can make that worse. And so exercise can really help people to manage those sorts of symptoms. And there's a lot of really good evidence now that exercise can actually help to improve people's balance, improve their fitness, help lessen fatigue, improve quality of life, all those sorts of things. So it really improves mobility and helps to reduce falls as well.
So as well as the physical reduction of falls and so on, how does it help in the management of pain? Can you explain that?
Yeah, there's actually, in terms of exercise for pain management in people with Parkinson's disease, there's very little work that's looked at that. So we actually don't have a clear understanding about that. But what we do know is that people with Parkinson's are about twice as likely to have chronic or persistent pain as people in the general population. And we also know that in the general population, exercise is part of a broader suite of therapies that is useful for helping people with chronic pain to manage that pain. So I think for people with Parkinson's disease, we really need to take a holistic approach to pain in Parkinson's disease. The medication's obviously incredibly important, but so is looking at exercise, and so is looking at other contributing factors like sleep, or things like psychological factors like anxiety and depression. So it's a broad part of that, but exercise specifically is so important for people with Parkinson's disease. I think although there's not strong evidence that it helps manage pain, I think people with Parkinson's who have pain still need to be exercising. And if they do experience pain, they need to be seeking out a physiotherapist or an exercise physiologist who understands about Parkinson's disease, who can help to carefully tailor people's programs so that they can hopefully improve their pain, or at least not stir it up and get the benefits of exercise, despite the fact that they might have some problems with ongoing pain.
Thank you. I'm just going to come, if I may, now to Kristin Arthur, our speech language pathologist, and I think Stephen has a question as well. I'll come to you in a moment, Stephen. I can sense that through the machine. But we've been hearing about the value of exercise and getting onto it quick, smart. And I think that's one of your key messages, isn't it, Kristin, when it comes to speech and swallowing, that to get therapy early is critical. Can you explain that?
Yeah, thank you, Julie. Yes, we call it early intervention, or just getting onto it early is very important. We have a good couple of handfuls of clients who have come to us and said, I have a diagnosis of Parkinson's, and I haven't experienced any voice or speech problems yet, but I understand it's a symptom. We know that 80% of people with Parkinson's will experience problems with their voice, reduced volume and slurred speech at some point in their disease journey. And they thought this is really, and for most of these clients who come to us, they say, look, it's so important for me to be able to keep talking. I need to keep working. I need to keep socializing. My friends are everything. My family, my grandchildren. I've just had some new grandchildren. I really want to keep talking to them and telling them stories. I really, really want to make sure that I don't lose my voice or my speech. And so we definitely can help those people. We teach them what it is to have a really strong, robust voice, how to get the best out of their voice, how to use their voice without abusing their voice. And then we can give them strategies to exercise plans and deliver the therapy ourselves to help them not to maintain their voice, because it's so much easier to maintain a function you already have or maintain a strong voice you already are using than it is to try and fix a voice that is no longer working for you. So get in early and do the exercises. The exercises can be really, really fun, and they can be done in lots and lots of different ways. We often encourage our
as some of this audience know, I had a cancer with radiation treatment, and so I actually lost speech for 3 or 4 months. And I can have vivid memories of myself sitting at home doing my exercises, and I fell in love with my speech pathologist because I wanted to get it back. So I know the power of your work. We don't have time to go in any detail, but there are 2 particular approaches that you are involved with: LSVT and speak out. Just in a nutshell, what are those 2 approaches to voice and swallowing about, please?
Okay, so they're both very well researched. There's lots of evidence to show that they work very, very well for people with Parkinson's disease. They've been designed specifically for people with Parkinson's disease. LSVT, or Lee Silverman voice treatment, I guess is the most well known, in my experience anyway. It's the one that I became a certified clinician in first. And the key element of that therapy is loud. So people might have heard of LSVT loud to strengthen your voice. There's also LSVT big. So Natalie, you'll know what LSVT big is, I imagine, as a physiotherapist. So anyway, back to LSVT loud. The core concept, the thing we repeat over and over and over again in therapy is be loud. Do everything. Be very strong with your voice. The other a therapy program we can deliver as an alternative to LSVT. They are very similar, but the key concept for one is loud, and for the other one, called speak out, the key concept that we repeat over and over and over again through all the exercises is the concept of intent. So we do still focus on loudness with speak out, but we more focus on intent. And we find that the concept of intent is really, really helpful for our clients, because you not only can you speak with intent, but you can do up your pants with intent. You can walk with intent. So it's helpful in other areas, that concept, that habit of doing things with intent in Parkinson's is a little bit more broadly helpful.
Just before I come to Stephen for his question, that the notion of being kind to your voice, I got heaps of advice about how to maintain my voice. And 11 years later, I still use it. Just a couple of tips of how you're kind to your voice.
It's common sense, really, but it's always good to get reminders of common sense. Staying hydrated, really, well, thank you for the demonstration. Thank you, Julie. Staying hydrated. And learning how to use your voice most efficiently. I think you can hear in most people's voice if your voice is fatiguing during the day, if you're often getting a hoarse voice, maybe you're not using your voice most efficiently. It doesn't have to be a symptom of Parkinson's disease. So learning how to use your voice well, and not abusing your voice. Voice rest. If you've got to the end of the day, it's very, very, if you've lost your voice or it's very sore, just resting, and hopefully it'll sort of recover the next day. And if you have a throat infection, if you're not well, not pushing through and talking through that, giving your voice rest when you have a throat infection as well.
Thank you. The one thing I've noticed is I've been told to avoid noisy rooms. Don't try and communicate in noisy rooms. And so I don't go to big dinners or anything anymore. I stay in that quiet. But look, I just want to give you some deaf sign clapping to both of you. And could I just ask, before I come back to Alan, Steve, did you have a question that you wanted to ask?
Yeah, I did actually. It was for Natalie, and it's a bit controversial, but it might resonate with other panelists and Simon's work in neuroprotection, pharmacological neuroprotection. Do you think that exercise in general, or more specifically exercise therapy, is indeed disease modifying or neuroprotective, neurorestorative?
The jury's out on that one, isn't it? I think the evidence indicates there's a possibility that maybe it slows the disease down a little bit. It's a possibility, and it's not having a massive impact on disease progression, I don't think, from the little bit of evidence we've got, but we don't have any really strong trials which have been able to sort of speak to that. But what we do know very clearly is that exercise optimizes people's abilities. So it really helps to manage the Parkinson's motor impairments. So I think by becoming stronger and fitter and improving your balance and things like that, you're optimizing what the person can do, and it really helps to control their motor impairments and therefore improve their ability to perform their daily activities and to do all the things that they love and enjoy doing. So if it's slowing disease down, well, we'll take that as well, but we don't really know at this point. Yeah.
Thank you very much. Alan Schell, if I could come to you, sir, another question from our audience.
I think importantly from that discussion and from our poll, we had variously 15% of people no exercise. And then the question is, should it be two a week, 3 days a week, 4 days a week? Should it be with a exercise physiologist? Can it be with a local physiotherapist? Can it be with the well-understanding gym trainer? I mean, I think exercise, you're quite right, should it be the 30 to 50 minutes 3 times a week for our cardiovascular health? So exercise obviously is a very important question, but I think ideally, what's a good range to have? From the poll, we see there's quite a range.
Natalie, take it away.
There's a lot in that question. Let's just unpack a little bit of it. Those of you that are familiar with the Australian government's physical activity guidelines for people over 65 will know that they recommend at least 30 minutes a day of moderate intensity exercise or activities. That's what makes you, start to huff and puff a little bit. They recommend trying to do that on all, if not most days of the week. That could include things like gardening or going for a walk or doing other dedicated exercise. I think, though, in terms of specific exercise programs for people with Parkinson's disease, if people want to get a really good, easily understood guideline for that, then there is the National Parkinson's Foundation in America a year or two ago put out some Parkinson's exercise recommendations. So in a nutshell, they recommend aerobic exercise 3 days per week for at least half an hour of continuous exercise, or you can break it up into smaller chunks. They say strength training 2 to 3 non-consecutive days per week for about half an hour per session. What they call BAM exercise, or balance, agility and multitasking type of exercise. So that's where you might focus on balance, or you might do something like some Tai Chi or some dancing, that kind of thing, 2 to 3 days a week, and then some stretching exercises most days of the week. So in a nutshell, that's what is recommended. It feels like a lot. It feels like a lot to anyone, but I think people should keep in mind that this approach doesn't need to be all or nothing. It's all or something. So, you know, something is always going to be better than nothing. So that's what people can aspire to. But, you know, start out with what you can manage and try and build up from there. And I think for people with Parkinson's disease, a physiotherapist or an exercise physiologist who knows about Parkinson's disease is really important. So a local physiotherapist may or may not have the Parkinson's disease knowledge. And I think that knowledge is really important to make sure that the exercise plan is tailored and safe for the person with Parkinson's disease. So someone with milder disease, probably some general information from a physio or an exercise physiologist who doesn't necessarily know a lot about Parkinson's disease might be okay in the short term for the people with very, very mild symptoms. But as the disease progresses and people are noticing the symptoms more, I think it's important to see a therapist that understands about Parkinson's, and they can tailor it to the person's impairments and the person's goals and their abilities, and make sure it's tailored and safe for them. And they can also introduce things such as sort of movement science type strategies to really help people with Parkinson's disease to move well as well, and learn activities.
What do you mean by movement science activities? Could you explain that?
Yeah, so looking more at the word escapes me right at this moment. Meg Morris is the researcher who's done a lot of work in this area, but looking at activities such as using cueing strategies to help with freezing of gait, different tips or tricks you can use to help with movement, to help to walk better and to take bigger steps, breaking tasks down into smaller chunks to be able to perform them a little bit more like what Kristin was talking about, a bit more intentionally or deliberately. And those sorts of strategies and tricks can really help people to improve in their movement and the way that they move, as well as looking at you know, different ways of training balance and getting the challenge right on the balance exercises. Those sorts of things can be really, really important. But as we heard for what Kristin said before, I think the message is start, you know, it's never too late, but it's also never too early. It's good to be proactive and start as early as possible. So did that unpack that big question enough?
It's a great answer. Ladies and gentlemen, everyone, we've only got about 20 minutes left. So what I'd like to do is ask our technical whiz, Nat, to bring everybody onto the screen, and we'll try and get through as many questions as we can in the rest of the session with a little bit more conciseness if possible. So Nat, if you could bring everybody on, and I'd like to come, if I may, first to Professor Simon Lewis, the neurologist and Professor of Cognitive Neurology at Macquarie University. We made a mention earlier, and I just can't see Simon if we're able to bring him onto the screen for some reason.
You might just have to change your view, Julie, to gallery.
Could you just fix my brain? I'm going to get one of those wires to come down to help me remember that. But if I could come to you, Simon, I know we've mentioned dementia and Lewy bodies earlier, just briefly, but I think one of the groups of questions coming through goes to people wanting to understand what is the relationship and the risk if you have a Parkinson's diagnosis for diagnoses of that nature, dementia or Lewy bodies. Could you explain that, please?
Yeah, so this is a matrix moment. So if you don't want to know the answer, you should tune out for the next few minutes. So those of you who are still watching, Parkinson's disease is associated with an increased risk of dementia. The figures are quite brutal, and what it says is if you have Parkinson's disease for 20 years, given an average age of onset, about 8 out of 10 of those patients will go on and get a dementia. Now, that doesn't mean to say if you're diagnosed at 50, you'll be demented at 70, because the younger your onset, the less likely you are to go on and get a dementia in that 20 years. And typically things like dementia tend to happen in the last 2 years of life. And so, essentially it's not a numbers game. It's more nuanced. Now, there is a raging argument going on about whether dementia with Lewy bodies and Parkinson's disease should all be grouped under one heading. I'm in the no camp for reasons that relate to how the prognosis of those conditions differs and how the pathology differs. I have posted a link to one of the videos on my website explaining the difference between dementia with Lewy bodies and Parkinson's. And then the final aspect is about Alzheimer's disease and Parkinson's. And they are different pathologies, but if you have any brain pathology like a degenerative disease, you're more likely to have something else as well. So effectively at post-mortem, where we look at the brain of Parkinson's disease patients, we will see coexistent Alzheimer's pathology in around 40% of those brains. But the bottom line is that Alzheimer's pathology, if you like, is something that makes the cognition worse, but wasn't responsible for all of the other bits that you saw leading up to it, the tremor, the slowness, the stiffness. So I think you have to be a little bit nuanced about what we're targeting and what we're describing.
And my understanding is one of your, in the context of this rather challenging condition, you think it's important for people to be very wary of hype stories in the media that offer apparent solutions. Could you speak to that, your concerns there?
Look, I think the truth is that everybody who's involved in Parkinson's and research is very excited to talk about their work. And often what happens then is that when it gets to be a very short 100-second item on the news, it gets spruiked out of all proportion. And people think that there's a new cure, a new diagnosis. Wow, this has happened. And I think that people really need to realize that when you see something on the television as a soundbite, there's probably a lot more behind it. And some of that is well-intentioned and well-natured. So, there are recent stories that have been on about therapies that we think will come to Australia in the coming months, but they're not here yet. And, patients come in and go, I hear there's a new treatment that's going to cure. And you go, it wasn't actually that story. And we see this with other things where there isn't really enough evidence to be, if you like, confident that that thing is going to do what you believe it to do. So I think people just need to be careful about overreading. And also one of the things I learned when I was doing my research was follow the money, find the story. So often you'll see a spruiked story which will have this fantastic new hope for Parkinson's disease. And actually, if you get down to the editorial, what you'll realize is that 6 rats that were given a model of Parkinson's disease were tried with a new therapy. Half of them didn't die in 30 days, and they're trying to spruik for investors. So you have to be very careful about what the story is trying to tell you. I think most of the stories we see on TV have got, good basis for them, but we do have to be a bit guarded in what we take home from those 100-second sound bites.
I saw you, thank you. I saw Associate Professor Stephen Tisch nodding madly there. When we spoke tonight, you said that Parkinson's is incurable, but not untreatable. You can see improvements. So faced with some of the tough things we've just heard, where do you see the main hope going to? In your experience, what both is it about a psychological attitude of the patient, the level of family support, or is it some of the treatments you offer? What helps people cope the best?
I think all of those things, Julie. I think you've covered some of the really important themes. I think it's important to instill sort of cautious optimism at the diagnosis because people don't know what they're in for. I try to present it more as a chronic disease model, different but similar to, say, diabetes. Diabetes has prognostic implications and risks as people move forward. However, like diabetes, it requires careful, regular management, a certain amount of self-discipline, and a certain amount of buy-in from the patient to take ownership of their disease and treat it themselves. So, you know, I think we need to move away from sort of considering Parkinson's disease as a completely incommutable object. Yes, it is at a kind of biopathological level still incurable, but that doesn't mean it's untreatable. And I think the more treatment that we give and the more coordinated we are in our treatment efforts earlier in the disease with all of the specialists that you're seeing today, we can shift the needle. And then on top of that, we've got, you know, some of the pioneering trials that Simon's leading that I'm lucky enough to be involved in that are actually adding to that, and possibly with something to actually slow the disease down. And I think I sort of add a bit of sort of temper people's enthusiasm with cures. When they ask me about cures, I say, look, I think a first step would be something to slow the disease down a bit. If you had a drug that could slow the tempo of the disease down by 15% reliably in most patients, that would already be a huge advantage, because all of your symptomatic therapies would still be operating. You could still do your allied health, your exercise, your social interaction, your well-being, your social engagement, cognitive training, and all the symptomatic therapies we currently have. And your disease would be progressing 15% slower than it would have otherwise progressed. So what I see, the landscape of neuroprotection being one that's incremental with sort of baby steps at first, and a bit like when HIV was first sort of entering its first phases of treatment, it went from being a very dreaded and, you know, sort of feared disease to something we've more or less neutralized with effective therapies so that people have a near normal life expectancy, good quality of life. I'd love it if Simon's work reaches sort of its full fruition and we can, you know, have in our hand, you know, effective disease modifying therapies that we can give to patients regularly to supplement everything else that we're doing. So I'm sort of cautiously optimistic, cautiously hopeful.
Look, thank you. Simon, can I just ask you, does the rate at which people deteriorate vary, and the sort of symptoms of the illness that they get vary? Like, is it quite a varied and individual thing?
It is, and we've used the word heterogeneity a little bit earlier, where essentially what we're saying is that, yes, you fulfill the diagnosis, but you're different. Now, people have proposed that there are subgroups of patients, so people who might have more in the way of tremor, less in the way of cognitive decline, people that might have more in the way of stiffness and balance problems, more in the way of cognitive decline. And effectively, I guess it's very hard to know which kind of patient you are. We know that younger onset patients have a slower disease progression, and we know that people who get the disease a bit later on are more likely to run into trouble sooner, but that's because they may be in their 80s and getting a lot of other pathologies anyway. The truth is that for people like Steve, myself, Natalie, Kristin, they'll tell you the same thing, which is, if I have a handle on how you are after about 3 years of disease, I can pretty much tell you what the future is going to be. We do get a couple of curveballs where perhaps the diagnosis may even get changed, but after about 3 years, the disease tends to run true. So if it's going badly at the start, it keeps going badly. If it starts slowly, it generally keeps going slowly. The end of Parkinson's disease, you do see that kind of drop off where people get more problems, balance issues and memory issues, but that tends to happen, as I say, in about the last 2 years of life. And the average life expectancy isn't greatly shorter in Parkinson's disease now that we have all these effective therapies.
I'm going to take a question from Alan, and then I want to come to you, Mary Kay, and see if there's something we've forgotten that we must mention. But another question from the audience, please, Alan.
So I think following on from the issues around the subgroup of patients, and I know that we often talk about Parkinson's as having a genetic basis or a sporadic occurrence in the community. And with the sporadic, and I think it's quite a relevant question, is it because we had a COVID vaccination, we had the flu when we were younger, or we had childhood vaccination that caused the problem? So with the sporadic, which obviously for some people just happens, no genetic influence, are there other mitigating circumstances that may have precipitated the disease?
Can I come to Simon and then to Stephen and get a comment from each of you, please?
Yeah, look, I think the truth is that if we said, when we look at genetics, there are sort of two things to look at. causative genes. That is to say, you have the gene, it gives you the disease. And the number of patients who've got that scenario is very small here in Australia. Certain communities, in Israel, for example, where the Ashkenazi Jewish population are much tighter, those rates go up. But in Australia, below less than 2% of patients who have a gene that you say that's caused this disease. There are risk genes, and risk genes are genes that you might carry and increase your risk, but don't mean to say you're definitely going to get the disease. And it's true to say that about 10% of patients in Australia will carry a risk gene that we've already identified. And the question in some ways going forwards is, over the next 20 years, how many of these risk genes will we identify that might help us to explain what it is that predisposes you to perhaps, whether it's inflammation, whether it's because you had some other insult, toxin, pesticide, whichever, that makes you more likely to be the person that goes on and actually gets Parkinson's disease. Steve, is that fair, or you've got some more as well? I
completely agree. I think it's fair to say we also see familial clustering without identifying a gene, even when we apply our very powerful genetic tools. And I think it's sort of a bit like we're looking for a spelling mistake in a library and we don't even know what book it's in, let alone what page it's on. So there may still be a genetic signal in there, but we haven't really nutted out where to look for it. And there's some good quality work going that Simon and I are sort of involved with, looking at large cohorts of PD patients at a genetic level to see if there's commonality, to try and see if we can find more genes for Parkinson's, because that might provide treatment targets or early diagnosis tools as well. I think Simon summed up the majority of the known possible risk factors, but many of them don't apply to the average patient. So it's very hard when a patient earnestly looks me in the eye on the day of diagnosis and say, why have I got this? I have to be honest and say, I really don't know. And that's obviously a really sort of feeling of failure in a way as a doctor, because, giving a cause for disease is probably one of the most important messages we can deliver. And we use terms like idiopathic or sporadic to mean that the cause is largely unknown.
Idiopathic and sporadic. What's the nub of it?
I think idiopathic means that no exogenous or external cause has been identified, that it's in some way an intrinsic disease event intrinsic to that organism. But it's also a sort of fancy way of saying we haven't got a clue. But these terms are still important, because while still we don't know, it's better to have a placeholder of saying we don't know rather than pretending we know. Because once we start sort of kidding ourselves that we have all the answers, we're going to stop looking. So I actually try to be as honest as I can about that. And most patients, after a little initial period of deflation, when they're told that, are rather accepting of that.
Frankness is good. We trust you when you're frank. Mary Kay Walker, if I could ask you to turn on your mic, and is there a topic you'd like to emphasise or a question you'd like to ask from Parkinson's New South Wales?
Look, no question springs to mind. I think what we've heard tonight from the researchers and clinicians has been a good overview of Parkinson's, the diseases, the trajectory, the things you should be doing. And I guess I'll end with the note that Parkinson's New South Wales is there as a place for people to ring to get information. Thanks for the shout out, Natalie, a little earlier. Thank you. So we're there for people to get the information and the referrals to appropriate clinicians. So I think the topics that have been covered have been spot on this evening.
Could I ask you a question? It strikes me a multidisciplinary team approach is clearly important. I come
absolutely
cancer patient from a system where they gave me a team. Suddenly about literally 12 people entered my life for a period of about 5 years. But I don't think that system is here in Australia. And so what's been going through my mind is, if you're living outside of residential care, you need family or clinical support to develop a little team. But I'm also interested, if people do need residential care, the level of exercise that's being recommended, or the level of the encouragement to do the speech and swallowing exercises, not every residential aged care is going to have enough staff or expertise to do it. So does family play a critical role in all this?
Oh, absolutely. We always talk about the statistics of people with Parkinson's in the state and in the country is X, but families and carers make it, almost 60% more. It impacts on so many people around the person with Parkinson's. But you make a good comment around the multidisciplinary team, because everybody's combination of symptoms are different. Everybody's treatments almost have to be individualised, and you have to have a team of specialists and clinicians around you to help you with your condition.
Look, our time is almost up, but I just want to say, as someone who had a life-threatening disease, we haven't talked a lot about counselling or psychology, other than the importance of peer group, if that's available. Kristin Arthur talked about running such a group for younger people at Wolper Jewish Hospital. But I find that nurses or allied health professionals, because their appointment is longer, because clinicians, you're often under such the pump in terms of the brevity of your appointments, that if you can find a clinician of allied or nursing with whom you have rapport, they can play a very important psychological support role. Would you observe that as well?
Absolutely, and we think that a lot of the phone answerers, our info line folks, the registered nurses and the allied health that we have on our info line, if, for example, the person has rung up to speak to a counsellor or get a referral to one of our counsellors, they've spent 15-20 minutes talking to our nurse, and at the end they'll say, so do you want a referral to our counsellor? And they go, no, I'm fine, because they've talked it out already. So some accidental counselling does happen for sure.
Thank you. Alan, we've only got 3 minutes, but is there something critical that I've missed that you'd like to alert us to, and I can get a quick answer?
A short question, and we know that people get, we call essential tremors, or tremors that they can't quite control. Is that a precursor to Parkinson's disease?
Simon, could I come to you, sir?
I'll let Steve take this one because it's got a bit of overlap with his treatment.
Thank you.
Thanks, Simon. Both Simon and I will see patients with essential tremor and also with PD, and often that clinical differentiation comes up. In general, if people meet criteria for essential tremor, we could go into what that really looks like. It's generally not considered a precursor to Parkinson's disease. There's some evidence that it might slightly increase your risk, but in terms of one leading to another, that's a relatively rare event, not unheard of. So in my practice, I've probably got a handful of people who started with essential tremor, with really just sort of tremulous hands, maybe a little bit of head tremor, but none of the other symptoms that we've been talking about tonight, who then after perhaps 5, 10 or 15 years of essential tremor, then started to manifest Parkinson's disease. And that sort of transition from essential tremor to Parkinson's disease is now embraced in the 2018 MDS consensus classification as Parkinson's disease with antecedent essential tremor. So it does exist, but it's considered relatively rare, thank goodness, because ET is also very common. And it would be really a very confronting prospect if everyone with ET was to go up and develop PD, but luckily that's not the case.
In essential tremor, is that essentially just a little bit of shaking? The definition.
I hate to say it, but it's another one of those idiopathic, slightly genetic conditions where there seems to be sort of rogue circuits misfiring within the brain that cause trembling, mainly with reaching and holding. So unlike Parkinson's tremor, where the hands tremble at rest when they're sitting in the lap, often with a little bit less tremor when the hand is in flight. In essential tremor, it's sort of the inverse. So the hands tend to be still in the lap and then really start tremoring when reaching and holding. So it's more disabling with respect to eating, drinking, handwriting than PD tremor. So it causes disability in its own right, but it doesn't bring all of those other myriad of issues that Simon was alluding to.
Ladies and gentlemen, everyone, our time is up. Do you mind giving each other a deaf sign clap? Because you've really done a marvellous job. And I just thank you so much. And I really thank Alan for joining us and for being our GP question moderator. It's so lovely to see you. And I want to thank you, the audience, as well as our panel, and a big thank you to Parkinson's New South Wales and Mary Kay Walker, and that obviously a great source of information. We're going to email you a feedback survey, and please fill it in. The Wolper team, and thank you to them, they really do read them, and we modify what we do and topics come up, so please fill it out. And in terms of, and remember, this is filmed and it will be on the Wolper Jewish Hospital website after a few days. And our next gathering is on Wednesday, the 17th of July, and the topic is stroke, recognising symptoms and warning signs and practical ways to reduce your risk. So we'll be talking about stroke on Wednesday, the 17th of July. My name's Julie McCrossin, and even with such a serious topic, it's been an absolute pleasure being with you. Thank you and good night.